Welcome to Learning Thursdays. We're pleased to be with you today to talk about postvention response after an overdose death or suicide. I'm joined with some colleagues today who will talk with you about the impact that overdose or suicide deaths have had on their staff and the steps that they take in the aftermath to support staff wellness and patient wellness. First, we will begin with introductions. My name is Bridget Hartman DeCenzo. I'm the manager of the OASAS Learning and Development Unit. I also oversee impaired driver services. Prior to my work at OASAS, I was an outpatient social worker in an addiction setting, and I also was an employee assistance professional. John.
Hi, I'm John Bennett. I'm the executive director of the Genesee Orleans Council on Alcohol and Substance Abuse out in Western New York. I've been working for OASAS license programs for 34 years, and I'm happy to be here today.
Hi, my name is Rachel Handler. I'm the Executive Director for Behavioral Health Services for St. Peter's Health Partners. I oversee services at Samaritan and St. Mary's Hospitals in both mental health and addictions, and have a lot of experience in the suicide prevention arena.
Hi, I'm Garrett Lloyd Lester, Director of Community and Coalition Initiatives at the Suicide Prevention Center of New York State. And prior to that work, I worked for Cortland County Mental Health for a number of years. Really excited to be here as part of this effort, and collaborative effort with OASAS and OMH and the Suicide Prevention Center to see how we can continue to support efforts that both are engaged in as it relates to clinicians who have experienced a loss by suicide or overdose.
So thanks, Gara. It's an honor to be sitting here with all of you today. Earlier in the year, OASAS held a meeting with some certified providers who had experienced recent overdose deaths or suicide deaths. We wanted to learn more about how it's impacting their staff. And what we learned is that the programs are doing the best they can to get by, but staff are very stressed, morale is diminished, and some people are leaving the field. We've also learned that overdose deaths are not only impacting the patient populations, but they're also impacting peer communities and, in some situations, addictions professionals. So obviously, this has taken a big toll on our workforce, and it's difficult to escape. So those programs that we talked with did bring grief counselors on board after a death, but few of them had a formal protocol in place, and that's why we're here to talk with you today. So after some researching, we found that there really isn't much out there pertaining to postvention protocol after an overdose death. Those protocols have long been in place for suicide, and so I reached out to the Office of Mental Health for some assistance. We do have a multidisciplinary work group that's meeting on a regular basis since February, and we have developed a plan to support our workforce. So we have developed two guidance documents. Both of them are in final draft stage. One is about postvention after an overdose death, and then the other one is about opioid overdose prevention in behavioral health settings. Both of these documents are going to be available very soon on a newly released web page that's dedicated to the topic. There will also be multiple other resources on that web page, so look for that toward the end of September. In addition, we are planning some additional Learning Thursdays presentations on the topic, and we do plan to have some training of trainer sessions in 2019 to seed the field with more training on this topic. The other thing that we did was we surveyed OASAS and OMH providers, and we received over 1,000 responses to that survey, and so I'd like to review those results with you now. So as you'll see by the slide, 59% of the respondents were from an OASAS setting, 23% were from an OMH setting, 10% were dually licensed, and then 16% were characterized as other. We wanted to know how many traumatic losses people had experienced within the past 12 months, and we defined traumatic loss by overdose death, suicide death, or some other type of an unexpected loss. And what we came to find was that 71% of the respondents had lost at least one client within the past 12 months. We also wanted to know the type of guidance that they needed from us, and 52% wanted guidance on postvention, 28% wanted guidance on prevention, and 21% would like guidance on policy and procedure related to traumatic loss. We also offered the opportunity for people to ask us questions in that survey, and we are going to be responding to some of those questions in our presentation today. Now we'll move over to some national overdose death statistics. The CDC did just update their statistics in August, so we have some new ones to report. This is 2017 data. You'll see that 197 Americans now die every day from overdose. Drug overdose deaths have spiked drastically for 3 years in a row, and drug overdoses killed 72,000 Americans in 2017. It's a staggering amount. Specific to New York State, between 2015 and 2016, there was a 32.4% increase in overdose deaths, and in 2016, there were 3,638 unintentional drug overdoses as reported by the CDC. This map that you see here of the United States is the number and age-adjusted rates of drug overdose, and you'll see that New York State is in the 16 to 18.5 range, which puts us in the mid-range as compared to other states throughout the U.S. This next graph is from the Department of Health based on CDC statistics. You'll see that it's the age-adjusted rates of overdose deaths involving all opioids, heroin, and opioid pain relievers in New York State, and it compares 2010 to 2015. So the overdose deaths from all opioids doubled in that time frame. From heroin, it's 5 times higher, and then deaths related to opioid pain relievers is still on the increase, but thankfully not as high as compared to heroin. New York State has been combating the opioid epidemic from several angles, and so I would be remiss if I didn't talk briefly about some of our most recent updates specific to the work that OASAS is doing. We are the recipient of state targeted response funds from the federal government. So there are 35 counties that have received those funds to increase access to treatment, peer services, and medication-assisted therapies. In addition, this funding also is going toward prevention services, naloxone training, recovery centers, and to develop a youth and young adult-driven recovery infrastructure. We also have a medication-assisted treatment for prescription drug and opiate addiction grant. That's a mouthful. We call it MAT-PDOA at OASAS. And the goal of that grant is to expand access to and quality of MAT services in high-need areas. Our Prevention Bureau is in receipt of SAMHSA's Partnership for Success grant, which is, the goal there is to push environmental prevention strategies out to reduce non-medical use of prescription drugs and heroin. And we have had a significant expansion of services to include family and peer navigators, open access centers, youth clubhouses, and recovery centers. And 2 recent updates from our legal department. There are no prior authorizations for inpatient or outpatient care for New York-based insurance companies, and the Ombudsman program will be going live on October 1 to assist people with coverage issues. And this is just a visual depiction of all of the campaigns that OASAS has been involved in to educate the public about the dangers of addiction, the dangers of using opioids, trying to bring down the stigma and let people know that recovery is possible and it happens. We're really proud of those campaigns. So now we will go to a couple of slides that bring suicide into the fold here. And what you're going to see is that Both suicide and unintentional overdose deaths have been increasing since 1999 in New York State. The opioid epidemic is fueling a sharp rise in drug overdose deaths. These deaths of despair, as characterized by Case and Deaton, are on the rise and fueling an increase in all-cause mortality among all age groups. And now I am going to transition it over to Gara.
Thanks, Bridget, and for that overview of the scope and scale of opioid deaths in the nation and in New York State. And I would imagine, as is often the case when we look at suicide data, attempts or completions, that those are probably underreported on some level. So I'm going to take a look at a little bit of what we know regarding suicide deaths and attempts in the country and in New York State. And before I do that, I always try to remind myself that it's important that we have data and information to inform the work that we do, to look at resource allocation. We need good data and information for planning, but we also don't want to lose sight of behind the data points, behind the percentages, our individuals' lives that have been touched and impacted. And so it's just for myself, certainly, and for whoever the audience is a reminder that this is really important work that we're looking to make sure that we have a good understanding about. So this first slide, I think, is really instructional when we think about the efforts and the impact that we can have on any number of different public health issues. If you look at this graph, you'll see that the impact that we've had over the last 15 years on reducing the rates of stroke, of heart disease, cancer, drug overdose, all causes. Over a 15-year period, we've seen a fairly significant drop in the age-adjusted death rates, with one exception, and that is if we look at suicide. Unfortunately, we know those rates have gone up. And so that sort of tells two stories, right? One is that we need to continue in this work and addressing hopelessness and despair and isolation and thoughts of suicide. We need to continue the good fight, right? It also tells us that if we continue to put efforts and resources into that conversation, that we can make a difference, as is noted by some of these other causes of death. If we start looking nationally at some of the most recent suicide statistics for 2016, we know that the confirmed completed suicides were 44,965 confirmed deaths, and that translates to a rate of roughly 13.4 individuals per 100,000. For any public health issue, we always talk about the rate as being the number of individuals per 100,000, so it's not a percentage. And we know, as I referenced earlier, that when it comes to completed suicides, the research would suggest that the actual number is anywhere from 5 to 25% greater. And we also know that, unfortunately, there has been a steady increase over the past 15 years in the number of confirmed suicides. Nationally, suicide is the 10th leading cause of death for all ages and second leading cause of death for youth. Suicides now surpass deaths by motor vehicle accidents, homicides, and breast cancers, right? So the needle is unfortunately moving in the wrong direction in many respects. If we drill down a little bit and we take a look at New York State, we know that in 2016, there were 1,679 confirmed suicides in the state. And so comparing that to the national numbers, our rate of suicide is about 8.5 individuals per 100,000. So when you compare the rate nationally to New York State, our rate is relatively low. But when you look at the actual burden, the actual number of individuals who have suicided, only 5 states had more confirmed suicides than New York. So while our rate is low, which is good news, the burden is fairly significant. And that has shown a 32% increase in the past decade of completed suicides in New York State. More than 2.5 times the number of homicides. We know that the profile in New York State, similar to nationally, more than 75% of suicides are among men. And when we look statewide at the primary methods of completed suicides, suffocation, firearms, and poisoning, as you can see by the slide, are the most significant. If you take a look at a county-by-county level, then you will also see that in many upstate rural counties, the most significant method tends to be firearms. When we take a look at this slide, right, it tells us that men represent almost 3/4 of all deaths by suicide and unintentional drug overdose. And so New York State 2015, we see that 73% of men are represented by drug and unintentional suicide and unintentional drug overdose, 27% women. So this is true typically of national statistics as well. When we think of loss by suicide, as you look at the bottom there, 1,213 men died by suicide in 2015, and for women it was 439.
And the same gender differences also are true for the drug overdose statistic.
So we see a lot of similarities in that respect. And again, as a reminder that these are underreported in most instances. So we're going to transition to some of the work that is happening in New York State and around the country right now. And it's called Zero Suicide. And the idea of zero suicide stemmed from the National Strategy for Suicide Prevention in 2012. And a task force was formed to look at any number of different areas nationally of how we can impact suicide prevention. And one of the target areas was suicide prevention in healthcare. It was this idea, if we're going to do suicide prevention well, we should really be able to do that in healthcare settings, both primary care and behavioral health, where people would anticipate and expect to get good quality prevention. And so, as the result of a number of experts from around the country and around the world, they began to look at what do we know about what works, what's effective in suicide prevention in healthcare. And they came up with this model called Zero Suicide. And looking at the frame starting in the upper right, it sort of talks about what is zero suicide. So it's important to recognize it's not a program, it's a framework. And it's really founded on the core belief that suicide deaths for people under care are preventable. That's the starting point, right? That we can prevent suicide deaths for people who are in healthcare settings. It's not a program, but it's a set of specific tools and strategies that healthcare providers, right, can use and target individuals. It was built upon work that's done successfully by several healthcare organizations. So again, we took a look at what do we know that works, right? The Henry Ford Healthcare Organization in the United States Air Force had some programs decades ago that were in part used to model the Zero Suicide program. And lastly, from a conceptual standpoint, zero suicide, it's an aspirational goal, right? And so one of the ways it is often talked about is if the goal is not zero, then what is the goal? What's acceptable when we think about how we talk about suicide prevention? So it is something aspirational, and that's really one of the driving elements of zero suicide.
And Gara, if I may, so as you hear Gara talk about the zero suicide model, you're going to be able to draw some parallels in your mind as you think of opioid overdose prevention. So think about that as he's talking about it, and know that we are looking at this model. OASAS is looking at this model and the concepts to see what we can apply to opioid overdose prevention. It may not be a perfect fit, but it's something that we are actively discussing with OMH, and you will be hearing more from us about this in the near future.
And that's a great point, because this is not about reinventing the wheel, and this work is already happening in OASAS, maybe just not under the title of zero suicide per se,
Sure.
but a lot of those conceptual things are happening. So if we drill down a little bit more, what's zero suicide? So there's 7 primary elements that are that define zero suicide, and it's the framework for systematic integration of suicide prevention in health and behavioral health care settings. And absolutely that includes mental health, substance abuse. And it starts with looking left to right. It starts with an explicit commitment at the health system level to reduce suicide attempts and deaths. So it starts with leadership, if you look at that first block on the left. It's really a change in culture of how we look at doing suicide prevention in the healthcare field. It also includes training, right? We want our workforce to feel confident and competent to address suicide, no matter what a person's role is. Somebody who's in billing, somebody who's in a clerical position, and certainly somebody who's doing treatment. We want everybody to have a comfort level of addressing the topic of suicide prevention. We also talk about the need to identify, right, who might be the individuals who are already vulnerable or struggling or at higher risk for suicide. How do we do that in a thoughtful, intentional manner? How do we engage individuals to make sure that there is a net around people and engage people in the work that needs to be done to help keep individuals safe? How do we treat people? How do we treat people using the most recent knowledge base of what we have in suicide, in the field of suicide prevention? There are many transition points that happen in care, right? And that's when people can be at their most vulnerable. So if somebody is being discharged or stepped down from one program to another, how do we make sure that we are doing those transitions in a thoughtful, careful manner? And then lastly, but certainly not leastly, how do we make sure that those efforts are having the intended consequences? How are we looking at sort of that continuous quality improvement loop to inform efforts going forward? So those are the 7 primary elements that really reflect zero suicide. Another way that we look at suicide, zero suicide, is that focus on patient safety and error reduction. We know that without improved suicide care, right, as evidenced by this graphic of the Swiss cheese model, that people are slipping through the gaps, right? We need to have a layered approach, right, to prevent that serious injury or death from occurring. So if we have this suicidal person that comes to our attention, right, from the healthcare setting, how do we help support that individual? So it starts with asking, right? Just some basic screening questions is part of best practice.
Hey, Gara, can I just mention something? So for the OASAS setting, asking, so from that very first interaction with the client, asking the clients about obviously their use. Have they ever overdosed before? Have they ever witnessed an overdose before? That, you know, we really, it's so important, just as with suicide, that you ask at first and you continue to ask throughout the episode.
Right, and that's a great point. So certainly upon first being introduced to somebody, right, you need to ask those important questions. But you also need to make sure that those questions get asked on a regular basis because situations change, life changes, right? If you ask and you get a positive answer, then we need to really engage that individual, specifically looking for safety, right? So if somebody's endorsed that they're thinking about suicide, they've made an attempt, right? How do we help increase safety for that individual in the short term, certainly, but then longer term as well?
And in parallel for that, for overdose, would be, has this person ever been trained on how to administer naloxone? Do they have a naloxone kit? Do they have a prescription for naloxone? We want to make sure, again, even if it's your very first interaction, that they have what they need. Absolutely.
It's for that individual. Certainly the providers have a role in this, but so doesn't the individual themselves that we're working with. If that person is engaged, one of the things we want to know is, do they have a plan? Have they thought about how they might consider ending their lives? And we know that there is a good evidence base for lethal means reduction, right? So if somebody has thought about the ways in which they might try to end their life, right, how can we build safety specifically and individually for that individual around that? And if they don't have a particular plan, right, how can we make sure that we can, again, try to build in safety in the event that situations might change? So we really want to be thinking about a personalized, tailored approach for that person in terms of means reduction. Right, and then we have to treat that person's suicidality, right? And we need to make sure that we are not looking just at any possible mental health diagnosis or substance abuse, but we really need to look at what's going on with that person specific to their suicidality. So we want to make sure that we're using the most recent evidence-based treatment that's known to be effective in treating that person's suicidality. And then lastly, we want to make sure that there is support there when it's needed, right? So when people are coming into contact with a healthcare setting, right, they're getting the supports that they need, but people are going back to their communities, or going back to where they live and where they work and where they play, right? So we want to make sure that there is adequate follow-up and supports necessary for those individuals. And what does that look like? And how do we make sure that we continue to keep people engaged in treatment and in recovery? Right, so we think about this as the zero suicide care pathway, right? And for healthcare systems, we think about what does that pathway look like for individuals. And in New York State, we're really fortunate to be doing quite a bit of work, and really, in many respects, a leadership capacity of zero suicide across the nation. So if we tie all of these things together, right, if we have that pathway to care, then we can anticipate, right, that people are much less likely to fall through those gaps. So this next slide are the results of a workforce survey done with OASAS clinicians as part of an earlier statewide grant, the National Strategy for Suicide Prevention. It was done with OASAS clinicians in outpatient settings in Erie and Monroe County. It was used as part of an OASAS Learning Collaborative. And if you look at the left pie chart, you'll see for individuals that have experienced having worked with somebody that died by suicide, about 31% of the individuals at that point in time had that experience. And when we look at individuals who have worked with somebody that's attempted suicide, we see that that number jumps up fairly significantly, which is not unusual, to sort of see that type of discrepancy. 14% indicated having worked with more than one client that died by suicide, and about 60% worked with more than one client who had attempted suicide. So if we start to think about the exposure and the impact that this topic has, we see that it doesn't really discriminate by healthcare settings, certainly. So we want to pivot now. As Bridget mentioned, we're going to talk about postvention. And postvention is a term that's been around in the field of suicidology for roughly 45 or 50 years. And it is, while somewhat specific to the field of suicide, as we'll hear later during the program, that there are a lot of parallels between postvention and suicide and postvention related work with other types of tragic unexpected deaths, including opioids. There are a number of definitions that you could probably find related to postvention. I think for our purposes, and one that is maybe more operational in nature, is that postvention is a series of planned interventions for those affected by an overdose or suicide. And so planned is really the operative term, right? You want to have some type of procedure, some sort of pathway already in place so that in the event of a loss, we're not scrambling to figure out what to do, that people's roles are defined, that we have systems of communication set up in place, that we have the ability to support each other. So postvention from the get-go should really be something that's planned in nature. You don't want to be in the moment trying to make decisions that are ultimately going to be very emotionally based. And so why would you do that in the first place? Why would you spend the time in postvention? Certainly it makes sense to spend time and resources with prevention and intervention or treatment. So some of the benefits and the values of spending that time in the prevention planning are going to be able to help facilitate the grieving or adjustment process in the event of a loss. Really to begin to stabilize that environment, because regardless of the setting, we know that for individuals that have experienced a loss, right, things are going to be unstable. There's going to be any wide range and variety of emotions. We engage in postvention planning and activities because we want to reduce the risk of negative behaviors. In particular, we want to limit the risk of further suicides through contagion, which is a relatively rare phenomenon, but it is a known and researched phenomena that suggests that exposure to somebody else's suicide can increase one's own risk, especially for those who are already vulnerable. And while there's not a lot of research and literature in this, the same could also be concluded for individuals that have experienced any type of tragic loss, including opioids. In this work, we think about postvention then as equaling prevention, right? So if we engage in thoughtful, planful postvention activities, we believe that that can also lead to prevention of further loss, of suicide or other unexpected death. So just from a very high-level overview, what are some of the prominent themes for survivors? And this is looking in particular at individuals that may have experienced a loss by suicide, but as we talked about, right, there are very likely to be parallels, right, for individuals working with clients with substance abuse disorders. Not surprisingly, one of the first and predominant themes that survivors face is this question of why. How do you make sense out of something that just doesn't make sense? Right, and so if we think about the idea of postvention in part being the desire to help people through the grieving and the adjustment process, and you couple that with the question of why, that can be really challenging, especially when, unfortunately, the only person who can really answer that question isn't with us anymore. For many survivors, there's this sense of responsibility, this sense of guilt and blame. What should I have done? What could I have done differently? Did something I do or say contribute to this person's actions? Or did something I didn't do or say contribute? Right, so many survivors will express feeling a sense of guilt. Trauma, right, for many individuals, it might be if, for example, somebody came across their loved one who suicided or died by an overdose, just that immediate exposure to having discovered a loved one or a friend or a family member can certainly, right, include a sense of trauma. But it doesn't have to be firsthand. It can also be secondhand knowledge. The way in which somebody finds out about that loss, right, can be really impactful in both a positive and not so positive manner. Certainly anger, right, is not an uncommon theme that many survivors will experience. How can this person do this? Didn't they know there was resources? Didn't they know we cared about them? And so anger can be a very predominant feeling that many folks might experience. Relief is also something that might enter into the fold in terms of a prominent theme, right? So imagine, for example, a loved one, a family member, a friend who's known somebody that might be struggling with thoughts of suicide or struggling with addiction for a number of years, and the operative term is struggling, right? And they've maybe really been wrestling with whatever has been going on. And there's a sense of pain for that individual. And if they do end up suiciding or dying by overdose, right, their loved ones or friends or family members, while likely to be very sad and distraught, might also feel a sense of relief in believing that that person is no longer suffering. And those conflicting emotions can be really challenging as it relates to grieving and adjusting. We talk about shame and the stigma associated with suicide, with overdose, and for survivors that may have experienced that loss, that shame and that isolation that can go along with it can really compound the ability to grieve and to heal. I have had the good pleasure of knowing a number of loss survivors who have, one individual tells a story of having been in a supermarket not long after her son died by suicide and having a neighbor come around the corner, see them and turn around and go the other direction, not out of any bad feelings, but just not knowing what to say or what to do. And so that really can cause an increased sense of isolation for that person who, again, is trying to make sense out of this loss. And then lastly, we know that exposure to another's suicide, and this doesn't have to be familial, can increase one's own risk, especially if somebody is vulnerable to begin with, right? These themes are not necessarily going to be present with everyone, and it's not a linear kind of a progression, but you can well imagine, if it's been a loss by suicide or a loss by overdose, that the ability to try to help somebody grieve and heal and to get back to that, quote, new normal can be really challenging, especially if there aren't protocols and policies and information and resources in place. So after talking about all of that, after looking at the data that we've looked at, after just briefly touching on Postvention, it's really important that those of you who are watching this today really take time to practice self-care, right? As people in the helping professions, we're often good at giving lip service to that, or we might talk about that more as something that you all should do, but maybe we're not always good about doing it internally. And you all are valuable resources in your workplace for the people who you love and care about and that love and care about you. So it's really important that if I was to ask each and every one of you watching this, what do you do for self-care, that you can name a number of things that are restorative in nature and that you find the time to do it. It's literally a life-preserving kind of activity. So if we think about Postvention as being a planful activity, right, and if it's intended to engage systems and individuals in the event of some sort of loss, one way to think about, so who would we be engaging? Who would we want to be paying attention to? This circles of vulnerability mapping process gives us one way to sort of conceptualize that, right? So for individuals, for example, that had some sort of geographic proximity to that loss, maybe they discovered the individual that died, or maybe they lived physically close to that individual, right? We would suspect that those individuals might have some degree of vulnerability. For individuals that have some sort of psychosocial proximity to the individual, they knew the individual well, maybe the individual was a victim of bullying and they were a bystander, they were friends with that individual, right? If you think of concentric circles, how close were they to that individual socially? And then the last circle of vulnerability is there an existing vulnerability? Is that person, that survivor, already vulnerable? Do they have a pre-existing condition, mental health or substance abuse disorder, right? Are they already vulnerable prior to that loss? So if we take a look at any one of those circles, and especially if somebody has more, right, than others, then those are absolutely individuals that we would want to be paying attention to, that we'd want to be on our radar to make sure that we're checking in with and touching base to see if they have the supports necessary, to see if they have the resources necessary. So now we've got an opportunity to talk to each of you and to talk to each other, really have a conversation and a discussion about this topic. So thank you for being here. And we want to start off just to have you maybe each share how overdoses and suicide loss have impacted the work that you do and the programs that you're involved with. And you know, our understanding is that you know, it's a sort of a timely discussion, right? So if one of you would like to sort of start us off in terms of how this work is.
Sure, thanks. And thanks both of you for the great work. Thank you for OASAS for really, you know, enhancing the conversation and taking the lead, and especially your department, Bridget. So you know, our community has been especially hard hit with the overdose epidemic. Looks like the coroner's initial data that's coming out of our one county, looks like we're going to be at 31 deaths per 100,000. And you heard Gara talking earlier about how that's a marker. So that's probably going to end up being one of the highest in the state. And just this past week, we have a bad batch of fentanyl going around our community, and we had 4 overdoses out of 4 overdose deaths last week out of 7 overdoses. So my staff, the community at large, you know, has been hit hard. We're doing a lot of really good preventive type things out there. We've got a 3-county opioid task force that we co-chair with the Department of Health. We're partnered with the criminal justice system. In fact, we're actually, they're very progressive out there. We're starting to look at doing Vivitrol. We just opened up a methadone clinic last week. And so we're doing some good things, but my staff really have taken the hardest hit. And so from that perspective, you know, last week I did go down and touch base with my staff and talk, especially with the folks who lost somebody last week. And they really are at a point where they're struggling. And everyone is so individualized when it comes to how they deal with grief and how they deal with this. And obviously it depends on where they come from in terms of whether they're new in the field or whether they're a seasoned clinician. They've had some training in this. You know, I'm excited to be here today with Rachel and Gara and Bridget anyways to talk, just to, you know, expand on this conversation. It's a little bit of what's going on in our community.
Thanks, John. I think that when I think about our community, we're not experiencing a current uptick, if you will, like last week your community had to experience. But this is really a chronic issue, right? So our task or our charge, I think, is that our workforce has an emotional tax to the work that we do. We also have the honor to serve people who are struggling and the ability to make an impact in people's lives. But with that comes an emotional tax and a burden that really challenges our workforce. And then when everything we've been working to avoid becomes, excuse me, becomes the outcome, there is a tremendous impact on our staff. And we have, I think at a leadership level, a real obligation to identify best practices and supporting them as they continue the challenging work, and be very mindful about how that support system wraps around the people who are exposed to that over and over again.
So can you talk a little bit more about what you're seeing in your staff? How is it impacting them?
Sure. So I think I actually asked this question of my staff last week, and the very first response was, it really sucks. I mean, what's going on for them? That was their, you know, blatant, honest response. Sure. But in terms of, and it's been everybody from my directors. I mean, one of my directors has lost 5 of her long-term patients over the past year, and so she's been significantly impacted. And then she's also in a role of, you know, caregiving and supervising staff. So one of the things I think, though, that my staff, you know, we've created the culture in our organization that they can talk amongst themselves. They know that you know, their supervisors are going to come in and meet with them. But I think the biggest thing is that some of the fear of going back out and working with the next patient in terms of, you know, what if it happens again? And you know, what if something I did played a role in that? And so really this taking on a no blame, you know, mentality in your organizations really is important from the top down.
You know, when I think of the slide that Gara had put up in terms of survivor response, that's what I think, to your question, Bridget, that's what our staff go through, right? They go to the grief response, they go to anger, they go to a shaken confidence or a perceived sense of responsibility. Certainly, we've had professionals who question their clinical competence or their journey. Sure. And we're very fortunate. We also have an opiate-related task force for our community. We're on the zero suicide journey, trying to ensure that we have a competent and caring workforce that has the tools that they need. And so, you know, when we look at it from an administrative angle, what can we do? We can do those things. But I think, you know, Bridget, it is a career-changing potentially career-changing experience to lose someone to either suicide or an opiate-related death. And it's a journey that's navigated differently depending on the individual, the clinician, how seasoned they are. And I think even when I think about opportunities for improvement for those of executives watching, I think we tend to be better at an immediate response than we are about the long-term support offered to people, because like anything, we're pretty good right away at recognizing impact. But as the impact sort of extends or prolongs, we have to be mindful of that on a long-term basis as well.
One of the things we talk about in postvention work is it's a marathon, not a sprint, right? And so there has to be that immediate, what do we do? How do we support people? How do we gauge who might be vulnerable and whatnot? But absolutely, you can't just mark a date on the calendar, anniversaries, of something significant right. So it's great to hear both of you sort of talk about the individual response. Before being a clinician, we're human, right? So we're none of us immune to being impacted. We'll talk about this work as the ripple effect. If you drop a pebble into a pond, you're going to get concentric ripples that go out, and they're going to impact people. Doesn't matter if you're a supervisor, whatever your role is, right?
Well, I really think that for most of us in the OASAS arena right now, we're muddling through. I say we're muddling through this, and developing a more, we're just at the infancy of developing a more organized approach to managing this and to helping staff manage this. We've done a lot of good things, but it hasn't really been, I think, very organized and system-wide. It's been, this department does this and this team does that, and then amongst the team, you have folks who really deal with this in a really spiritual and positive way, and they enhance the whole team. And that's who oftentimes you'll find several members of the team in their office talking after an incident like this. And so we're trying to develop a little bit more organized standard of how we address this. So I love the postvention discussion.
Yeah, we brought it up in, so OASAS has a talent management meeting that meets quarterly, and we actually initiated this conversation in the talent management meeting, I believe, I don't know, at the end of 2017. And the response was exactly what you were saying. In the past, there would be an overdose death maybe once a year, maybe. And so now we find ourselves in this position, I shouldn't say but the programs find themselves in this position where you're dealing with it over and over again. So that kind of gets back to, what you were saying is why we're in the infancy, of this, because we've been thrust into a position that we really haven't had to deal with very often in the past.
No.
So.
Well, and I think, I'm so pleased that OMH and OASAS are asking the question, because I don't know that we know yet what the cumulative impact on the workforce is from traumatic loss. And in order to be good stewards, I think we have to be looking at, so of course we're always researching on the clinical angle, but we have to be researching the impact to our workforce and how best to take care of them so they can continue their charge of taking care of the patients that we serve or the people that we serve. I work in hospital systems, so forgive my patient language, but we really do have, when we think about impact or postvention, right, we respond to communities. And a treatment community is the same as any other community. So there's a connectedness to the people that we lose, there's a commitment and investment in their well-being, and there's a humanity and a general regard for the people that we serve. And so I go back to that slide in my mind. Our staff go through all of that. Sometimes anger, sometimes grief, sometimes a sense of responsibility, and working them through that process. I think our industry is positioned well because we have supervision structures that allow people sacred time to do some of that work. But I think we have a benefit of kind of harvesting best practices, having more dialogues like this, and sharing what works well in your community and how can we make something like that. You were talking about a lunch and learn concept. How could we do informal supports because people are drawn to one another in the offices? And how do we formalize that so that support's available to anyone struggling? I don't have the answers, but I think that the dialogue is a great starting point.
Yeah, yeah. And speaking of that, so let's get a little more specific about what the postvention protocol should look like. And Rachel, I know that you've been really involved in postvention over the years, so I'm just wondering if maybe you could take us through, an incident that you've, dealt with in the past, and how you got the call, and just talk to us a little bit more, put some context around it as far as your involvement goes.
Sure. So several years ago, we launched a postvention team as part of the Rensselaer County Suicide Prevention Task Force. And a couple of caveats, I think, or critical pieces. One is that people who are responders to a postvention are particularly trained. So for our model, or our experience in our postvention team, we ask that they be Connect trained. And that training sort of recognizes that ripple impact, the concentric circles, the potential impact to people both near and far, and looks at postvention from multiple lenses. What happens, and depending, interestingly, from an organizational perspective, we get the call one of a number of ways. So somebody hears about us, knows about us, somebody calls the Suicide Prevention Center or the local government unit, or I know about it from my provider lens, and we then kind of connect with the engaged circles, so the Suicide Prevention Center, the LGU, and then our responders to say, this treatment community had a loss, because we have gone out to a substance abuse treatment community, or a housing authority community, or a school district, and we identify who's available, and then we do a planning. We sit on the phone, we talk about with the people requesting service. So it's not, I do want to clarify this, it's not an outreach service, our postvention, and typically postvention is not. Typically it's an inreach, so you call and ask for your community to be responded to, as opposed to being aware that a community is struggling and then pushing the service out. Right. So that's one piece. But then depending on their needs, so in a school community, for instance, we met with faculty, we met with students, we did education, we reviewed guidelines for, for school management, because we want to be careful about how it's managed. And so we did work, we worked with the faculty on what to do around their actual curriculums, because they were worried that the content the next year was going to be really heavy. We work on how to manage that. So so that was a school, right? But we also went to an impacted adult living community, and they were all talking about how to recognize risk in one another, how to attend the funeral as a group and support each other. And we even did some base education on grief itself and how it kind of happens in waves, and how to take care of yourself while you're grieving. So I think our challenge then is taking what we learn in those interventions, community-based, and applying it to best responses for our impacted workforce. Because I think we're less likely to identify our struggle and to go about kind of continuing to take care of the next people we're serving, and making sure that we carve out time, or our protocols ensure that we carve out time for self-care. I don't know if that answers your question.
Yeah. Don, you want to talk a little bit about some of the steps that you've taken and recently?
So, so one of the models that we're looking at actually comes from a school-based model. It's called TIG. It's trauma, illness, and grief. And the local BOCES, Genesee Valley Educational Partnership, just put a COSR out to all their districts. So all 22 districts bought into it. There was a significant trauma in one of the school districts last year where a young student was killed. And so that's been a response to that. So what we've done is we've asked if we could buy into that service and have a TIG team trained through our staff. So I know it's a school-based model. We're going to adopt it. I've looked at the curriculum. It looks pretty good. And one of the things that we've done through our opioid task force and our criminal justice advisory council out there in Genesee County and Orleans County was to ask if we could have two teams, a community-based team that could respond to a significant incident, and then we're going to have a home-based team within the organization. So that's one of the models that we're looking at.
I think that's so encouraging, because this work isn't just starting. It's work that's happening, right? I mean, the TIG model is something, right, I mean, that is geared towards schools, but there are a lot of lessons learned that we can use, so we can sort of tailor that experience and that knowledge. Right, there are certain things that we would do similar in nature in the community and in an organization, and certain things that we need to take a separate path. But it's finding the time and space really to make that a priority.
And really, you know, we don't work in a vacuum. In our small community, everybody we work with works with the folks that we work with.
Sure.
So social services is impacted, law enforcement, first responders, probation, parole, and they, you know, come to really love some of these folks that they're working with, right? And they become attached to them. And so and really we've had a great response from the community already of people who would like to participate in the process. So we recognize that, like something that happened this last week has really had a profound impact on the whole community, and everyone's talking about it at every meeting we go to, and really kind of looking for us to take the lead, and we should take the lead. I mean, I think that providers need to be out in the community, and you know, and especially executives need to be out in the community talking about this, and letting people know that, you know, we're going to start to change the curve on this, right? The things that we can do, so as a community.
Yeah, I think it's really important to be out in the community talking about this. You know, we did a campaign on reversing the stigma, and I know with Zero Suicide, you know, the idea is to keep the conversation going, you know, from the top down. We've got to talk about this. We've got to normalize the conversation, you know, so asking about risk of suicide or asking about risk of overdose is just normal language that we use in our programs, but I think the same is true for the community. And so it's so very important to be involved to the best of your ability in the community on different community coalitions or what have you, so that we can educate, you know, the other systems that our clients are involved in.
That's right.
Yeah.
You know, Bridget, one of the things I think is an opportunity for all of us is that many of these efforts tend to be provider-centric, and what we really need is to engage key stakeholders that are community-based,
Sure.
so that our coalitions engage,
That's
for
right.
instance, the media, the first responders. So if part of our Postvention team was a police officer and a fireman and
That's right.
you know, a clergy member, then really it would begin to become a community. And our coalitions have been really good about that, recognizing that this is not a hospital or substance abuse disorder problem. It is a community issue.
right.
Sure.
And particularly a public health epidemic can't be addressed from one angle. It
Right.
has to be addressed from every angle. So I think there is some opportunity for us to continue the growth of involvement of key stakeholders in that effort.
You know, involving the families.
Yep.
I mean,
Absolutely.
these families, they really need a place to share their own grief, and so partnering with families in the community is huge. And there's a lot of good grassroots stuff going on right now with families and with peers. So I think that is an untapped resource in our communities, is the families that are dealing with this. The families who have lost loved ones, the families who are afraid they're going to lose loved ones,
Sure.
who don't know what to do with you know, their children or loved ones who are addicted to opioids. And especially when something like this is going through a community, when fentanyl is all over the place. You know, I had one mom say that she's sets her alarm for every hour, gets up and checks on her kid every hour, and she's got other children and she works full time. So, I mean, how, you know, what kind of life can you have if you're doing those kinds of things?
Sure.
So the support that they need around that is huge.
Yeah.
So that's the prevention part. I mean, that could be some of the prevention intervention part of it, is to really engage all those stakeholders you're talking about and address this from a community standpoint. It's really
And as you
good model.
referenced, for
Great model.
individuals that have experienced that loss, that feel they're in a good place, you know, whatever that means or looks like, you know, how can they also use that experience to inform? It comes full circle.
Sure.
Right?
And we've certainly had families who find purpose in contributing to the prevention efforts, or and again, I say prevention, I think about postvention as prevention, right? And so as we're talking about a community's impact in empowering families to play a role, so that I've talked to countless families who say, I don't want any other family to have to go through this. It's too much, it's too painful. And so for them, a sense of purpose is then gives them a way to keep moving, a forward movement. So if we can engage those families that are ready for that part of the journey to participate, it certainly helps us.
Some of this conversation, it makes me think, so we talked about the need to be, we're of the community if we're in a healthcare setting or whatnot, right? We're not just sort of up on the hill or whatever, and to educate and to engage partners. But then I wonder, so the lens is looking out in that respect, but if we turn the lens into our systems, right, I think we, generally speaking, do a good job of letting communities know what resources are available. But if we think about a loss that happens that, directly impacts our agency, do the people in our workforce know what resources are available? Do they know that it's okay to access them? So I wonder, your experiences, because we've talked about how, okay, there's somebody in the waiting room and life doesn't stop, right? There's this sort of this pressure, right? So I wonder what that might look like. Do people know how to access resources and stuff like that?
So I think in my organization they do. I think that we have a long-standing EAP. We have several counselors that they can utilize, and we encourage it. And so probably that's one of the first things their supervisor will say to them is, don't forget you can use EAP. It's obviously voluntary. I think also in the organization they know. Well, we just changed our policy. It's going to my board this month to offer bereavement for staff who are experiencing loss. And so the supervisor can make the determination if it needs to be more than one day or multiple days. We just really don't want staff to have to use their own personal vacation and sick time to be off if needed after a crisis. So we're looking at all of those things. But I think staff, we're still developing resources, but I think our staff do know what's available internally. Should.
Yeah, I think that they're aware. I think that their inclination to lean in or lean out is clinician or dependent or variable. Right. One of the things that I think we need to focus on, and I love that policy because I think it's geared towards taking care of our staff. Right. But I worry because we always have to balance it, and I do come at it from a clinical background, right? So for some people, being home alone with all my thoughts and all my questions can be a less safe a space than to be surrounded by people who are also impacted and who are also processing that. And so we try to have a conversation with staff about what would be most helpful for them at this point in time, and then maybe even tomorrow, or because I think it's dependent. Going home might be better. I think some of it is about, to your point, if I have people to see all afternoon, and our work takes concentration and focus and mindfulness, and sometimes that's really hard when you're distracted by tragedy, and legitimately distracted. I don't mean that as a negative connotation. But allowing ourselves enough time to heal and feel and go through the pieces that we need to. I have found that clinicians who lean in feel better, but again, that's so human variable.
Absolutely. So can we talk for a couple of minutes about the debriefing? Because I think that, as you think about developing an agency protocol, one of the things that you want to do as soon as you learn about a loss is you want to gather your staff to have a discussion about that. And I know that, so for some programs, bringing a person in may be the model that you use. For other programs, having agency staff trained may be the protocol that you use. I know the Veterans Administration has a team of responders internally. Let's talk about the debriefing. How should that go, and what are the rules for that?
I'll let you take that one first.
Okay, sure. I think, so it's interesting because I think the rules are different depending on circumstance. And we had a conversation kind of in preparation for this discussion about some of our regulatory requirements and reporting requirements, and then our staff needs. And they're not always aligning well.
Sure.
And our need to do what is best for both circumstances. So some of what we talked about in terms of rules, if you will, is making sure that the person responsible for the regulatory piece of this and the reporting end isn't the same person tasked with the emotional support to our staff. So having some kind of a clear sense of roles and responsibilities, and even a division of tasks, so that the same person isn't charged with being that primary support and walking through some of the root cause analysis work that we are asked to do. Beyond that, I think it looks different depending on the circumstance. I do think that multi-agency involvement, when it's permissible, is helpful. So to your point of the community you work with, the social services are impacted, your staff are impacted, and sometimes bringing those people, our housing providers, in together to look at it from every angle and to support one another through that process can be very therapeutic and helpful for our staff.
So, you know, you picked up on the administrative portion of what we, and we do have a task. I mean, I think in every organization, you have to take a look at what kind of care was given to the patient. So in our organization, my quality assurance person is going to be the first to take a look at the record. And then they're going to work with the director or the supervisor around how they're going to handle that. So it might be that the debriefing actually might be done just initially with the supervisor and the clinician, depending on what happened and what the scenario was, and or it might be done in a team setting. So that's how we're gonna do it. But eventually we're gonna have a TIG team or whatever we ended up calling it. And it is hard in our setting to involve community members, obviously, because of the confidentiality. So we have to be mindful of that, which is why we're going to have two teams, be part of a community-based team, but also have our own internal team. So that's how we're doing it.
Well, and I actually think there's two things. I think there's notification and I think there's debriefing. So to your point of the supervisor, somebody clinically connected to the staff member does the initial notification. And then the team, because we don't treat people in vacuums, right? We treat people typically from a multidisciplinary team. So for, psychiatry, we're talking about the psychiatrist, the nurse, the case manager, and the clinician, and then their colleagues.
Sure.
So I do think there's a difference between notification and debriefing. And in terms of notification, if we become aware first, really being thoughtful about how that communication happens. Who does the communication? What does the rest of their day look like? How do we manage that post-notification, or how do we time that in a way that is mindful of their responsibilities for the remainder of the day? And then think about how do we debrief from a team, program, department, community level? Because I think that there can be layers to that debrief.
Really important discussion, I think, for administrators watching this to start, if you haven't already, start thinking about, because it's layered, right? And it's multidimensional. Yeah. And like you hit on communication. So what about the clinician who's, on holiday or on maternity leave, just some of those things that it would be easy to understand how they might slip by, but that's why having that planned approach to the extent possible, I think, is really good. And then even just language, so debriefing. So what are we debriefing? Are we debriefing the incident, the loss itself, or are we supporting staff? And just having that shared language and those commonalities, I think, are important. And then you sort of touched or talked about it. So if this is happening within an agency, are staff required to go to something versus is it an option? And how do you negotiate that? And also, again, it's a marathon, not a sprint. So like all of those things really sort of, come together. And so it's really, I think, incumbent upon us to be thinking about not leaving it to chance, right? And it's not about me or you. It's about, this is how we do things in our organization. If there's a loss, boom, 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 we have policies for everything else, so why wouldn't we have something for this, right?
Yeah. Let me just say to that it's my thought that it should be voluntary, but if you create an organization and a culture in your organization that people support each other, they're going to want to be there at the table to support each other. Right. And there might be circumstances where somebody opts out, though.
So John and I compared answers to make sure we were on the same page before we did this, and we both felt like it should be voluntary. But I think timing, so someone's readiness to participate in that can vary.
That's
Is it, I'd like to opt out today, but if there was something maybe in a day or two that we could do, I might be more meaningfully able to participate. It's too close for right now. I haven't even had a chance to process my own feelings, the clinician may say. So I think there's a voluntary element, but we do want to keep putting opportunities for support in front of staff. And I also believe that supervision is not voluntary. So even if I can't get at it from a voluntary, I want to sit down and talk about a perspective, that again, we have at least a safety net where we
Sure.
can process
Yeah.
it with a clinician, because there is going to be an impact to their work, and we want to
Yes.
That's
make
right.
sure that we give them the tools and arm
right.
them with how to move forward as
That's a
a
good
clinical
point, Rachel. That's a great
provider.
point, actually. That
Yeah, I agree. It's a good distinction to make, and not everybody is going to want to participate
Right.
in a debriefing, and it should be voluntary. And I just also want to make sure that we convey that the tone of the debriefing is one of, it's not a blaming tone, it's a supportive, stick to the facts, but be supportive at the same time. And the importance, as we had discussed before, of separating out the process of, I think you called it incident management, from having a supportive conversation with staff, because really that's an important distinction to make as well.
Yeah.
the part about having to report it to the Justice Center and to having to cross your I's and dot your no.
Dot your I's and cross
Yeah.
your T's.
That one.
I think that is something that should be kind of just behind the scenes. It should just be routine, that this is what we have to do.
Sure.
And it really doesn't play into the actual, debriefing per se with staff. That really is more about, caring for the team. And so, again, I think that you made the distinction earlier of separating those two
Yeah.
out. And
Well, and I've worked in different settings so I've worked, I've overseen different clinical services, and in clinics, we don't do, let's say, a community meeting with the impacted clinical patient, client, consumer community, but in a day treatment, we might, because people may have been
Right.
attending groups all day with somebody, and suddenly they're no longer here, and what we can and can't communicate, and how we support the impacted community members, often, by the way, who know before we've had a chance to tell them.
Right.
So, interestingly, even while our staff are struggling, they're also continuing to take care of their community they're serving. And so they have to juggle and toggle these lenses, turn on and turn off their own responses, and it takes a lot of effort. And so as much support and as much buoying as we can do for them, I think is important, because it's hard to do that.
And there were a lot of questions that came to us related to what you just said, which is, how do we deal with the clients? What does that look like? From a supervisory standpoint, how should I act? How do I interact with clients so they know that I really care, or should I not? You know what I mean? So can you walk us through how you did that when you were working in the clinic and dealt with the clients?
And my gut response to say to you is that before we are anything, we are humans, talking to and working with other human beings. And so a person-centered, true emotional response. Now, that said, I tend to be, or my clinical staff tend to be, cautious about where they are in their process before they put themselves in a place to have to respond to a community. But candidly, they know we're human beings with feelings. And so I typically would to encourage my staff to acknowledge that. This is painful for me. I'm sure it's painful for you as well, and use it as an opportunity. I don't think hiding behind my title, right? I'm a staff member, so this doesn't, because it still hurts, and it's still painful, and it's, we're invested in the people we serve, and I think it does a disservice and a dishonor to that.
Sure.
To that connection as human beings.
And I think it's another way to honor that person who died,
Yeah.
right, too, is by being genuine and authentic and
Yeah.
real. So, no, that's great. Thank
And
you.
I think when we're not authentic, our clients know that we're not being authentic.
Yeah.
And then they feel that. And so I think there's more value in being less put together and more real than the reverse. Now, that said, if I'm not able to facilitate a grief discussion because of where I'm at, then I tee it off to my colleague or to my supervisor to say, and I sit there and I
Yeah.
say, I hope you know I don't not care. I'm just not in a place today to
be able to do
facilitate
it.
this. So I'm here with you to sit alongside you. I'm struggling with my own feelings about this and acknowledge them.
there may be a little role reversal sometimes in these scenarios. I mean, when you have a senior service director who has been working with patients for 20 years and loses a patient who, she loves and cares about, she's gonna have an emotional response, and she should. And the team is, I think, strong enough to wrap their arms around her also. The other day when we took our first patient into the methadone, I went down just to say hey and congratulate everybody, and then I walked out with one of my senior directors, and she was tearful, and I said, what's going on? And she said, I'm just feeling emotional today about the first patient, but she said, I can't help thinking about all the families that I'm connected with that this isn't going to help. And so on that note, I mean, I've been working with her for 20 years. I just gave her a hug and we moved on. But that, that's who the staff are who generally work in the field and the work that we do. They are always mindful and caring and kind and compassionate to the families and people we serve. So
it sort of makes me think that, I mean, despite talking about postvention as a planful response and having all these things to the extent possible outlined, to trust in your gut, like what do people need? I mean, again, it's that human factor. So we want to have a plan, we want to have a roadmap, but also, right, what does your gut tell you to do, and sort of go with that, right? So I think that was a really good way to sort of balance both of those, right? It's not either or, it's both and, right?
So one of the specific questions that we received, and I'm wondering if the two of you would like to respond, is what is the boundary between being supportive of staff and counseling them? And should it be crossed?
I think that our profession is almost entirely gray. So
that's a very good point.
That's good news. So I don't really have to answer. No. So I think there's a fine line between support and counseling. And what I don't think that when I'm doing support, or when my staff leaders are doing support, they are engaging and leveraging their counseling skills. And I would encourage them to do that. I think where I differentiate it is in terms of its length of time, or how long-term that becomes. If this becomes unresolved for you, Bridget, over months, and it is the theme of our supervision, and it is impacting your ability to function, either personally or professionally, I would encourage you to move to counseling, right? If the focus of our efforts from a support is, how can I help you through this so you can continue to perform your job function? If it takes a different spin, and of course we're human services people, so we lean in a little bit, but at some point this is really more for an exploration with a longer term therapist than it is for me, and then encouraging or offering or leveraging and connecting to EAP or established supports for that work. But I do think it's gray, and I do think that in any support we're offering our counseling skills to that relationship.
And I think that, too, with that, like as you had said, involving or suggesting EAP, I think is a great thing to do from the very beginning with everybody that's suffered this loss. It's just, we want to make sure that our staff know what's available right away. I have written up resource sheets and handed them out to people that have been involved, just so they know right off the rip. And then that way, again, you're providing them with more right away. And then certainly the discussion can stay about, how do you continue to do this job and care for others while you're in such a vulnerable place yourself.
Yep. And I think to your question very early on, what are the rules? I think one of the rules is to offer connectedness to services geared towards supporting that. There is a lot of research around clinicians as survivors, and there's some things coming to better prepare us for how best to support clinicians as survivors or clinicians as impacted, because there's this recognition that we're facing this, your staff are facing this 4 times in a week.
Right.
You haven't even processed one, and you're hit with another wave of information and tragedy. So, I don't know that any workforce is quite prepared for that.
No, but I would just ditto what you said. I mean, I think that it is gray, and the same thing. It would be the same, in supervision. If it just took on a different tone, we would work to get you connected, if you're not already connected or reconnected, to a counselor or a therapist, but there, we do work in a field where you always utilize those resources, right? So.
Well, I wonder, so we've been sort of talking in general terms, and rightfully so, about loss and planning and so on and so forth, but I wonder if either of you have had experience of, is there a difference in terms of how we would respond and plan if the loss was relating to a young person versus an adult? And is that, where do the paths diverge and the impact, and is that something worth noting in terms of a thoughtful, planful nature and the impact? I just wonder if that's something either of you could speak to.
Well, we certainly have had young people and adults. I think the family involvement with a young person is going to be more significant and hopefully already engaged in our system. I know that 2 families are recently engaged in counseling after, so they're seeing the therapist who worked with their child, and they see them a couple times a month, and so, but from a, really from a standpoint of how we would handle it, I think it would be handled similarly, and
the services I oversee are adult licensed services, but our postvention team responds regardless. And I do think that it differs, but I don't think it's age specific. It's requester specific. Sure. If I'm a school and I'm trying to address, how do we move forward as a school community, then I target my interventions and postvention response towards the school. Certainly, we see some differences in terms of how the community responds when it is a young person, and the sense of loss of potential and loss of life, and the nature of how it's interpreted by the community can really be significantly different based on age. And so we're mindful of that as we move into our postvention services, but I don't know that it's specifically age as much as how is the community responding, what does the community need, what is the ask.
So, I mean, and this has come up a couple of times, is this theme or this idea of to have a structure and a process, but also to be flexible, right? It's not a cookie cutter approach, that we maybe have some guidelines that we know we can sort of rely on and fall back on, but then what's the circumstances, what's the context, and we need to be, and that certainly applies to the work we're talking about within the clinical setting, right?
I think the other thing, when we think about postvention teams versus administrative responses that is different, is that postvention responses tend to be 1, maybe 2 touches. It's really a guide, an outline for how to move forward, connectedness to ongoing resources, can be planning for how does a community address this. But it's usually 1 or 2 touches, where the administrative responsibilities of oversight of services, so for OASAS and OMH licensed providers, that's ongoing. How do we support our staff in a long-term way versus going in for one postvention service to a community that's affected by a loss? And our goals are different for those 2 different things. So, and I think we're talking about both of them, so that's a distinction I would just make.
Yeah, and speaking of which, and John, you had alluded to this before, the importance of the culture, because I think it's the culture that the culture that you have in your program is going to be helpful or hurtful, in a time like this. So, so what do you do to develop a culture of support in your organization? Because I think that's also what you're getting to, Rachel, which is, beyond the postvention, how do we continue to support?
Well, I think, obviously the culture, I believe, starts from the top down. And so, your executive agent in an organization really has to be somewhat responsible for setting the tone. And so my staff know that I think about them, and my senior leaders are always having discussion about how we can improve, even without a crisis, how can we improve their work? How can we enhance your job satisfaction? We're often overworked and underpaid on our system, and so we are always looking for ways to enhance that. They know that my board is also on board with anything that enhances staff satisfaction. So I think that that comes from the top down, and then within the team we've set up a wellness committee, and so we have wellness activities. Even my prevention department was they're impacted. So other departments who aren't involved directly with the patient care, they see the other clinical staff, stressed or in tears. And so the other day, maybe this is going back a couple months ago, they wanted to do something. They felt like they needed to be empowered, so they put on a breakfast for staff. So it's just, it's little things in an organization that really help. I mean, so that involved all the other departments in trying to, at least offer some condolences and caring for the therapists who were involved. So I think I can't put anyone, pinpoint any one thing that happens, but we've also had a senior team that's been together for a very long time, and that makes a huge difference in an organization when you've got 15 to 20 years and all your senior leaders in the organization, and so you might have some more.
I work for a very large organization, so I think the culture, from a patient safety and quality improvement is every interaction we have around those are teaching or sending messages, whether they're intended or unintended, and so making sure that we actually participate in activities that are non-punitive, non-blaming, that when staff participate in a root cause, that it focuses on systems, processes, equipment, and I say equipment because that's healthcare in general, not typically our healthcare, but as opposed to a blaming environment, and to the degree that we create a continuous learning, and so when we go to a root cause and we identify something, what do we do with it? Do we then take it and broadcast it out so that we expand the learning and the experience that someone had? If there's a system issue, if there was a quality of care issue, how we manage that, I think, is critically important, and sends messages to staff that I don't even think they know they're interpreting. And then when you ask them, my organization does a safety survey annually, and it speaks to, do you feel like there is a culture of non-punitive, continuous quality improvement, and that affords them the opportunity to answer when they really think about it. But I just think we have to be mindful of how we do things, because the staff are taking lots of messages away from that.
I think the key is, what you just said, is to listen to your staff. I've got a safety committee and a wellness committee and several other types of organizational committees, and you just listen to what they have to say about this, and they'll tell you what they need, and you have to be willing or find a way as an administrator to make it happen.
There are organizations, and ours has done a little bit of this. Actually, they've done a lot. Behavioral health is starting its journey in patient and family advisory committees, because it's not just listening to your staff, but listening to the voice of the people you serve.
True.
Absolutely.
And even taking people who have had a not positive experience with your organization,
That's right.
that can participate meaningfully in improvement, and asking them, what are our delighters? What are our opportunities to better serve the community? And that also sends a message that administration is willing to hear what we do well and what we have to work on,
I think that's
and tells our staff. A lot of literature out there called PFACs.
Yeah. Okay.
Well, and that's so important. So it's not just about, okay, we've created this document of what we're going to do, and we have this supportive environment, but it's about learning. Okay, we thought this sounded good, or we thought this would work, but we're hearing from our staff, and so leadership, administration can set the tone that this is important. We're going to carve out the space. And I think that's what's been great about this conversation and about this collaborative so far, is it would be easy to sort of brush this aside, because you're doing the work that you do, right? But the fact that this has risen to a level of, we have to support the people who are in this field and in this work, so we don't lose people, so that we can encourage and support folks.
There's another idea I'd like to share, that we've been probably over the last several years doing something called compassion rounds. So, in healthcare, there's a lot of rounding on a case, or case conferencing like we used to do in our industry. But this is really rounding on the emotional tax that it takes to take care of somebody. So we've done a compassion rounds on an opiate-related death. We've done a compassion rounds, and it's an opportunity for people in the healthcare system to come together, talk not about the specific details of the case, but to talk about how it impacted the people working with them, how it impacted the healthcare community. And there are formal models like the Schwartz rounding, but we use kind of our internally developed Compassion Rounds committee that identifies challenging workforce issues and then brings them to Compassion Rounds. So some staff from hospice and oncology and behavioral health and addictions are all in the room together, pharmacy staff, and just talking, and there's a panel that presents on, their experience and the compassion fatigue that can come with the work that we do. And that in and of itself has a huge payoff. Staff, we fill the room. Staff come, they listen, they are empathetic to each other's experience. I don't know what it's like to take care of an oncology patient who is terminally ill, and how much that takes for the nurse. They don't know what it's like to go every day to a community that's at risk, and worry about them taking their own lives or worry about them dying to an opiate-related death. So this is a model that I think is easily spreadable for staff to take care of the larger workforce, and not always in the heat of the moment, right? Because we do that, but in that long-term way to have
And
some model.
how often does that happen?
We do it quarterly, and people from my organization who watch might yell at me and tell me I got it wrong. It's either every other month or quarterly.
Okay.
And the topics are identified by a committee, and the people and the case. I say cases, but it's not about an infection and what antibiotic we treated it with,
Sure.
or
Right.
it's about the impact emotionally from taking care of a difficult either case or outcome.
So it's similar to a roundtable discussion. I mean, just
Yeah.
yes, we do the
Very
same.
forward thinking.
We do the same
Right,
thing.
yeah.
I like that term you use.
Compassion round?
Yes.
I wonder if you can now talk a little bit, we're going to shift gears and talk a little bit about how you follow up with the family after a loss.
I mean, I think that's a difficult question, Bridget, because I think, like everything else we've talked about, there's a lot of variation. But what we recommend is that it's a conversation with your supervisor about what is appropriate within what context. And I think some of that depends on how much contact the family is asking for. And so we have often had to help staff navigate the questions of, do I participate in services? How would I identify myself? The questions we talked about. Right. And so making sure that there's a supervisory weigh-in on how we move forward. Because you're an individual, but you're also representing the organization. So we ask staff to get supervisory connected and approval.
Yeah, and just to have to make sure you have policy on that, because the clinicians need to go when they go out that they can't, share any identifying information even about themselves. They can't reference themselves as, "Hi, I'm from JACASA." So if a family member comes up to them and they're known to them and they engage them, that is a little different scenario. Sure. And one of the things that we're working on in our organization too is to when we have releases, to develop a package that goes out to families to offer support, including the family support networks that are in the community, because oftentimes they don't have that resource.
Yeah.
So we're working on putting together a package and coming up with a policy about when that can go out, how it goes out, and so it's a little bit of what we do.
So again, that internal communication and not making decisions in isolation, right, is like relying on the people
Right.
who are there as part of your team, right? We don't, even if we're working one-on-one, we don't do this work completely in isolation.
Yes, yes. So as we close out, I'm wondering if the two of you have some recommendations on first steps to take.
So first steps, Bridget, if nothing else, I would get a team together and start looking at policy. But you're not going to have to do it in a vacuum, because the document that Bridget was referencing earlier that's going to come out to the field later is going to be tremendously helpful. I had a chance to review the document, and if we had it when we were writing our policy, we would have based our policy off of that. And in fact, we're modifying our policy right now based on the stuff that's in that. So it's going to be really helpful to the field.
Great.
I would say to organizations and administration that you're not alone. So there are many of us on this path, and certainly some are further along. So I would lean into the regulatory agencies for their guidance. I would look at established best practices, and I would even encourage agencies to work with other agencies who are either on the journey or further along to see what we can kind of, what do we call it, steal shamelessly or borrow from one another. Because I think for our commitment to the industry overall, it's really about harvesting best practices.
Absolutely, and that's exactly what we did when we started working with OMH.
Perfect.
What are your best practices and what can we borrow?
Yeah.
And so, moving back to the slide really quick, what you're going to see is 2 documents that we recommend that you take a look at as you plan your policy. Again, ours is coming. It's going to be here at the end of the month. Clinical response following opioid overdose, a guide for managers. The other document was a document that Gara provided entitled A Manager's Guide to Suicide Postvention in the Workplace. We think that they're both great documents to consider. So I want to thank all of you for your time and for driving to Albany to be able to have this discussion today. I look forward to continued collaboration with all of you. So thank you for joining us and have a wonderful day.